Welcome back to the MedFlight Ultrasound Curriculum Part 3. Today we're finally going to get down to business and talk about finding free fluid in the abdomen and thorax. This is traditionally what people think of as the FAST exam, looking for blood in the abdomen of trauma patients. However, the concept we're going to talk about here today apply to any sources of free fluid in the abdomen or thorax, including ascites, ruptured ectopic pregnancies, pleural effusions, and empyemas. The key principle of all of these exams is that fluid will sink to the most dependent portion of the closed peritoneal space. Because most of our critically ill patients are supine, these areas of dependency settle around the spine's curvature, either in the pelvic region or adjacent to the large solid organs, the liver and the spleen. We'll also talk about finding intrathoracic free fluid, which also follows the same rules of dependency. We'll start by talking about three regions in the abdomen that are most sensitive for detecting free fluid. You probably already know these as the right upper quadrant, the left upper quadrant, and the suprapubic space. While this concept of dependency intuitively makes sense, it turns out that there are a lot of pitfalls to doing this exam, and as a result, this is the most difficult exam to master of all of the ASAP endorsed ultrasound studies. This is borne out in the literature, where the sensitivity of ED performed FAST exams is somewhere between 46 and 99% for picking up free fluid compared to the CT scan. The pre-hospital literature is even worse, somewhere around 30 to 50% sensitivity. As a result, I think that the most important thing to get out of this talk is that there are a lot of these pitfalls to getting definitive views when looking for free fluid. And if you're adept at recognizing limitation, you'll be much more likely to interpret the scans correctly and reap the benefits of the exam. What are these benefits? For starters, if you do see something on your exam in the correct clinical context, the specificity of these findings is quite high across many studies looking at this, somewhere around 99%. This exam is also repeatable and poses no risk for radiation, which can be particularly useful if your patient has a clinical change in their course during transport. So let's start out with the right upper quadrant. The most important thing to recognize is that this view is not just about the infamous Morrison's pouch, the space between the liver and the kidney. Free fluid can hide in three critical spaces in the upper quadrants. It can hide under the diaphragm, between the kidney and the liver, or the spleen on the left upper quadrant, and in the paracolic gutter, or the inferior tip of the liver. Let's look at the view itself. This is what you'll see when you put the probe on the patient's body in that coronal plane. Recall that the indicator points to the head, and the top of the screen is the superficial portion of the patient's body. To help you orient, let's recap that mental gymnastics. You turn the image up so that the indicator points towards the head, and then you point your image into the patient's body to get an understanding of what this looks like anatomically. Here's the view you'll see. The diaphragm is a hyperechoic strip attaching to the spine in the far field of the image shown in red here. The kidney is the bean-shaped organ, and the area above the kidney is Morrison's pouch, between the kidney and the liver. The liver is the large organ taking up most of the screen, and the inferior tip of the liver is the paracolic gutter, shown at the far upper right of the image, indicated by the green asterisk. This is actually the most important part of the view, because it is the first place that you'll see free fluid, and often a lot of blood can hide in that region. Here's the classic view of a positive FAST exam, with free fluid in Morrison's pouch, as well as in the paracolic gutter. Recall that fluid is hypoechoic and comes up black on the screen. Now, when you put the probe in that orientation, it's not enough to just hold the probe there. This is a dynamic exam, and you should fan or sweep through the entire posterior dependent portion, which is usually indicated by the location of the kidney. In this clip, we're capturing all three of those key areas with no areas of hypoechoic fluid, so this is a normal exam. Now, what about this view? Here, you're getting the area under the diaphragm, and you're getting into Morrison's pouch, but you're missing that inferior portion of the liver. If you slide or rock the probe down just a little bit, you'll see that this is actually a fairly significant positive exam with quite a bit of free fluid in the paracolic gutter by the inferior tip of the liver. Going back to that original clip, it actually just barely captured that sliver. So take a look at this. Right there. To be truly convinced though, you really need to visualize that inferior portion of the liver. This is why doing the exam properly can change your sensitivity from 40 to 90% so easily. Here's an even more dramatic example of the importance of the inferior liver tip. As this person scanned down, they saw a huge amount, probably equivalent to a liter or more, of peritoneal free fluid. Here is a clip that you will encounter all the time when trying to get good pictures. Here, all of the areas of interest are obstructed by a rib. There are a number of solutions to this which rely on the anatomy and your ability to move your probe around. The first thing is to try to slide into a different rib space. If that's not enough, you can try to use that blood-filled liver as what's called an acoustic window. To do this, sweep the probe anteriorly towards the front of the abdomen and point it posteriorly by fanning it towards the spine and kidney. Finally, the ribs run obliquely to the patient's body, so you can try to rotate the entire probe to fit into a rib space. If you didn't catch all of that, that's okay. When we scan together, we'll run into these issues and troubleshoot them together. What about this clip? This is a common fake out, especially in larger patients. It looks like there's something between the liver and the kidney that does not belong, but this is not free fluid. This is a perinephric fat pad. While the FAST exam is pretty specific, you need to be aware of this kind of abnormality so that you don't call an exam falsely positive. Here's another fake out. You'll notice a big hypoechoic region under the liver. It's tempting to call it free fluid, but notice a few things. First, you don't see the kidney. This usually means that you're too far anterior and fluid doesn't collect anterior. It collects in the posterior dependent portions. Second, the fluid isn't free. It looks like it's encased in a hyperechoic round bladder. That's because it is. It's just the gallbladder. One more fake out and then I'm done. Here's another spot that looks like free fluid, but again, it's got a bit of a hyperechoic case, and this one actually looks like it has branches. It's the IVC with hepatic veins dumping into it. So to summarize, free fluid has to be truly free. It's not surrounded by white lines. It shouldn't have internal echoes like perinephric fat, and it shouldn't have branches like veins do. It also has to be posterior and dependent. If you see the gallbladder, you're way too anterior. Let's move on to the left upper quadrant. In many views, this is similar to the right upper quadrant in that you have to look at the same three spots: under the diaphragm, between the kidney and the spleen, and in the pericolic gutter. Here's a normal good view of the left upper quadrant. You'll often get more ribs in the way, but as long as you see those three areas, you're in pretty good shape. Here is an example of a typical positive left upper quadrant view with fluid in the splenorenal space as well as under the diaphragm. However, due to the anatomy of the spleen, fluid will often be absent from the splenorenal space, even in very abnormal spleens. You can see here the spleen looks very irregular, and there's good visualization of the splenorenal space and the space under the diaphragm. This is a grade 5 splenic lac with fluid under the diaphragm just getting obstructed by a rib at the end of the clip. If you slide down a rib space, you see a much more convincing positive exam here. Unfortunately, the left upper quadrant has some other differences that you need to be aware of. If you take a transverse slice through the region we're ultrasounding, you'll notice that unlike the right upper quadrant, where the liver is large and gives a very nice acoustic window, the spleen here is much smaller and sits much more posteriorly. If you look at the next rib space up, you'll start also running into a big portion of bowel called the stomach. This can also make your life miserable if you have better things to do with your time than messing around getting the perfect fast views. Let's go through some quick things you can do to optimize this view. Here's what the stomach looks like. It's just a round, messy, heterogeneous loop filled with cheese curds and spotted cows. As you try to fan through this, you'll see a bits of spleen, but none of the three areas we talked about. The solution is to try to move the probe. First, try sliding up or usually down a rib space away from the stomach. Second, you can again try to rotate a bit to get the ribs out of the way. Finally, and this is the biggest difference between the left and the right sides, instead of sweeping anterior and pointing posterior, you want to sweep as far posterior and point a little bit anterior in order to take the best advantage of the dinky splenic acoustic window that you can. This is what we often refer to as knuckles to the bed, because you'll often be digging into the stretcher trying to get as far posterior on the patient's flank as you can. To make you feel better about all these challenges, here are some nice positive examples. If you see something like this, you're obviously done. There's fluid in all three spaces. Here's another positive one, with tons of fluid dissecting between the spleen and the diaphragm, which seems to happen a lot more on the left than the right side because the spleen is not as stuck onto the diaphragm as the liver is. One final pitfall that folks run into is focusing too much on finding the kidney. Remember that the kidney is retroperitoneal and free fluid doesn't show up well on ultrasound in that area. Instead, you need to direct your attention to these regions around the intraperitoneal spleen and liver rather than a retroperitoneal kidney. If you get nothing else out of this talk, I want you to remember these three areas that you need to look at to find free fluid in the upper quadrants, under the diaphragm, between the kidney and the solid organs of the liver and the spleen, and in the paracolic gutter or inferior tip of the solid organ. Finally, let's look at the last, most dependent part of the abdomen, the suprapubic region. Your landmark organ here, like the liver and the spleen of the upper abdomen, is the bladder. The biggest pitfall people fall into is they don't realize that the bladder actually sits in the pelvis, kind of like those files in Zoolander sitting in the computer.
In the computer. It's so simple.
As a result, people will often start looking somewhere just below the belly button, but you really need to go lower to see the bladder and the pelvic bowl.
Lower. A lot lower. Too low! Lower.
I don't really care if you don't get that reference, as long as it uncomfortably sits with you every time you do a FAST exam and you remember to go lower. Here's a view of the bladder, the big, round, fluid-filled sac in the middle of the screen. This is the transverse orientation, and you don't see much free fluid, although you do see that edge shadow artifact that we talked about last time. You can tell that it's artifact because it has some dirty white shadows within it, rather than looking like black fluid we saw in the positive exams earlier. However, on the same patient, when you turn the probe sagittally, you'll see what almost looks like a second bladder. Here it is a bit closer up. Green outlines the bladder itself, and blue is the free fluid. Note the irregular edges and finger-like projections in it. These finger-like projections are loops of bowel floating in free fluid. It appears from case reports like these that the sagittal view is much more sensitive than for free fluid, so if you have to choose one view, you should go sagittal during this exam. Here's another example. This view doesn't even capture the bladder. They didn't go low enough. But you can see those finger-like projections of bowel floating in fluid and can stop there because this is a positive exam. So let's review some of the pitfalls and pearls of looking for free fluid. In general, for the right upper quadrant, remember that the paracolic gutter is the most sensitive area, that free fluid has to be free, and that you can sweep anterior and point posterior to use the liver as an acoustic window. For the left upper quadrant, remember that a lot of blood can hide under the diaphragm compared to the right upper quadrant. You can focus in on it around the spleen and not the kidney, and that your best chance is to sweep down and point up, unlike the right upper quadrant, where you sweep up and point down. For the pelvic area, always remember to go lower. The sagittal plane is much more sensitive than the transverse plane, and loops of bowel are your dead giveaway that you're looking at free fluid and not a second bladder. Alright, at this point, you might feel kind of like me getting swept under this rapid of free fluid, but bear with me for a few more minutes because there is one more spot that you should be able to recognize as having free fluid. In addition to sloshing around in the peritoneal sac, free fluid can also occur in the pleural sac, above the diaphragm, as pleural effusions or hemothorax. The technique for finding this is actually quite easy and does not require much more work if you've already done the abdominal FAST exam and your eyes are attuned to the area above the diaphragm. All you have to do is slide a little bit cranially and look at the dependent portion of the pleural space right by the spine. Here's what you'll see in a normal exam. Diaphragm again is in red, and a bunch of nothing in the region where the lung is. Air does not conduct sound, and so a well-inflated lung will fill up the thoracic space and you'll just see nothing, or sometimes just random echoes bouncing around. Now, the most important thing to keep an eye on for this exam is the spine. As you point posteriorly, you will see these hyperechoic bony nubs, and in the normal exam, you'll notice that they stop right where the diaphragm inserts. Again, this is because sound is not traveling through the normal lung and can't get to the point where the vertebra will echo the signal back. As the patient breathes, you can take a clip, but ultimately, you don't want to fan anywhere else. If there's fluid, this is where you'll see it, and fanning will just get you out of your area of interest. Now, in a patient with a big effusion or hemothorax, that area that used to contain lung will now contain a ton of hypoechoic fluid, which acts as an excellent acoustic window. Here's the diaphragm, a little sliver of collapsed lung, and the spine now visible well into the thoracic area because of all of this pleural fluid here. This is known as the spine sign, and it's the most important thing you're looking for in this exam. Here's the patient making very scary, poor efforts at breathing due to all of this disease. Here's another example. Again, note the hypoechoic fluid making it possible for you to see the spine extending into the thorax. As a result, the biggest problem that people have with this exam is that they don't understand the importance of that spine sign. Beginners will often scan through the spleen looking for fluid in the chest. You can see here that this sonographer is way too anterior because they have such a good view of the stomach. The solution is to fan the probe just a little bit posterior in order to visualize the spine. So let's add the hemithorax to our view. Remember to look above the diaphragm in that dependent posterior portion in order to visualize the presence or absence of a spine sign, and to aim it posterior to find the spine. So that's it. Today, we talked about looking for free fluid in the abdomen and the hemithorax and the different pearls and pitfalls of finding that free fluid. Next time, we'll talk a little bit more about the apices of the lungs and finding pneumothorax and other lung pathologies, as well as basic views of looking at the heart to find effusions and cardiac standstill. See you next time.